Hi, everyone. Thank you for joining us. Welcome to Data for Impact's webinar about strengthening gender competency for family planning providers. During the webinar, we'll hear lessons learned using a provider self-assessment tool and an e-learning course focused on gender competency. Next slide, please. This webinar will be presented in English with closed captioning available. If you'd like to turn on English closed captioning, choose the live transcript CC button from your Zoom menu. Next, please. First, I want to tell you just a little bit about the project. I'm Tori Taylor, one of the project's technical directors, and Data for Impact, or D4I, is USAID funded. It's a consortium led by the University of North Carolina at Chapel Hill in partnership with Palladium, JSI, and Tulane University. D4I strengthens local capacity to generate and use high-quality health data for strategic decision-making on health policy and programming at the national, subnational, and community levels. D4I investigates programs' effectiveness, integrates gender into all of our activities, supports learning and adaptive management, and uses evidence. D4I draws on the technical expertise in each of our partner institutions and an extensive network of local partners in USAID's priority countries. Throughout this webinar, feel free to ask questions using the Q&A function in Zoom, but please don't add your questions to the chat. We'll do our best to answer all your questions at the end of the webinar. Next, please. The team that's going to be sharing this information with you today includes Catherine Andronopoulos, Evelyn Coco, and Jana Wisniewski. Catherine is the lead for this activity and is an associate professor in the Department of International Health and Sustainable Development at the Tulane School of Public Health and Tropical Medicine. She has 20 years of experience in applied social science research related to sexual and reproductive health, including family planning and HIV. Her work focuses on mitigating the impact of gender-related barriers and stigma on health outcomes. Evelyn Coco is a qualitative researcher with over 27 years of hands-on market research experience. She has strategically led teams to undertake several qualitative studies in Ghana and in the West African region. She's collaborated with a number of local and international agencies, Grace Health International, Embed Unit of the World Bank, UNAIDS, and more, to conduct social behavior and health-related studies over the years. Jana Wisniewski is an activity lead with D4I and an assistant professor, also in the Department of International Health and Sustainable Development at Tulane School of Public Health and Tropical Medicine. Her research focuses on health system strengthening in fragile and post-conflict settings, and on how the health system contributes to health disparities. She has extensive experience in applied mixed methods research related to health systems and service delivery and family planning. Catherine will share the main findings. Evelyn and Jana will join in for Q&A. Next, please. One very important team member who is missing today is Dr. Phyllis Dako-Jeke, who passed away on June 11th. Based at the University of Ghana and a member of the GEMNet Health Network, Dr. Dako-Jeke was a distinguished scholar and a public health advocate. She was dedicated to improving public health outcomes in underserved communities, and she was the project leader for this activity in Ghana. She helped develop the self-assessment tool and was integral to designing and implementing the tool's pilot and the e-learning course pilot that we'll discuss today. Phyllis was cherished by everyone who had the opportunity to work with her, and she will be greatly missed. We'd like to take a moment of silence to remember her. Thank you, everyone, for joining me in that remembrance. I'll hand it over to Catherine now for the main presentation.
Thank you, Tori, for that introduction. I'm very excited today to share with everyone findings from our recent work that was conducted by USAID, D4I, and Ghana Health Services to strengthen gender competency for family planning providers. I will begin by explaining the concept of gender competency in family planning and a tool and e-learning course that can be used to strengthen providers' gender competency. I'll explain the methods we use to gather provider feedback about these resources, as well as providers' opinions about them. Next, I'll explain how we design trainings using these resources and lessons learned about the strengths and weaknesses of each model. Finally, I'll summarize our conclusions and recommendations and open the floor for questions and comments. I'm pleased that many of the people who have joined today are implementers of the workshops from Ghana Health Services, as well as providers who attended the workshops, and I hope you'll be open to sharing your comments and experiences for others to learn from as well. Every day, family planning providers are faced with gender-related issues that complicate their clients' family planning decisions. These challenges can take many forms, from inequities in decision-making power between men and women, to limited skills in couples communication, lack of male engagement, and experiences of gender-based violence. Providers' own beliefs and attitudes about appropriate gender roles and behaviors from women, men, girls, and boys can also influence how they provide services. Gender competency is the knowledge, attitudes, and skills that can help providers reduce gender-related barriers for their clients. By gaining skills in gender competency, providers can better identify gender-related issues faced by their clients and help them navigate these issues so that clients reach their family planning goals. Recognizing the importance of gender-related factors in family planning service provision, USAID has supported a series of projects to help providers. This began with work by the Human Resources for Health 2030 Project, or HRH 2030, to establish the gender competency framework for family planning providers. Informed by formative research with providers in the Philippines and Ethiopia, as well as an expert review meeting, the framework outlines 6 domains of gender competency, as well as the knowledge, attitudes, and skills important for each one. Earlier domains established the foundation for the complexity inherent in later ones. These domains begin with gender-sensitive communication. They also include promoting individual agency, supporting legal rights and status related to family planning, engaging men and boys as partners and users, facilitating couples' positive communication and cooperative decision-making, and addressing gender-based violence. Following the establishment of the framework, the HRH 2030 project developed an e-learning course for providers designed to build capacity in each domain. The 7 modules of the course increase knowledge of the domains and provide examples of practical applications of concepts. It is publicly available and can be completed in a self-paced format. After completing all modules, providers passing a knowledge assessment receive a certificate of completion. As a complement to the e-learning course, the Data for Impact, or D4I project, developed a tool to measure providers' competency in each of the 6 domains. Having a measure of gender competency allows providers to better understand which areas are in need of more training. The measurement tool also can facilitate assessments of changes in competency achieved through training activities. Together as a suite of resources, the tool and e-learning course can strengthen the gender competency of family planning providers, ultimately leading to increased quality and uptake of family planning services. Informed by a literature search and expert review, the tool was designed as a self-assessment that can be used by individual providers to measure and reflect on their areas of strength and weaknesses in gender competency. For each domain, a series of statements were developed mapped to 4-point Likert responses that range from strongly agree to strongly disagree. These items were developed with feedback from family planning providers in Ghana and also in Uganda to assess the face validity and content validity of the statements for each domain. The tool includes the items and their responses, a scoring key, and a discussion guide. And a printable version of the tool is available on the D4I website. We've included links to both the e-learning course and this tool in the chat. The development of the tool occurred during the first phase of this activity, and as I mentioned, included obtaining feedback from 56 family planning providers. Once fully developed, the tool was used in a workshop with an additional 14 providers in Accra, Ghana, provided feedback on the tool, and importantly, ideas about how to design trainings using the tool and e-learning course that can be used by Ghana Health Services Family Planning Program to train all providers in the national program, as well as to give insight on how other countries might also adopt these resources. This feedback informed the third and final phase, which compares training modalities and elicited feedback from an additional 52 family planning providers in Ghana, and which is the focus of today's webinar. We use a variety of methods to collect information about the tool, e-learning course, and the modalities for implementing them in trainings. For each module of the e-learning course, providers completed an 8-item survey based on Proctor's implementation outcomes to measure acceptability, relevancy, and intended future use of the content. After completion of the tool, providers answered a 6-item survey adapted from the system usability scale. Providers completed the gender competency self-assessment tool before and after the e-learning course, so we used tool scores to assess changes in competency. We were also provided information about whether the e-learning course was completed from the Commonix team, which hosts the online platform for the course. Finally, we reviewed team notes about cost, materials needed, and common questions posed by participants. Qualitative feedback was also obtained in the form of small and large group discussions and open-ended text boxes for providers to write comments into the surveys that I mentioned. I'll first present feedback on the content of the tool and e-learning course extracted from the surveys, small group discussions, and open-ended text questions. In our piloting of the modalities, we included providers that would give us diverse perspectives in terms of cadre, sex, age, and average years working as a family planning provider. In terms of cadre, 39% were nurses, 22% midwives, 11% physicians, 10% community health workers, and 18% other. A mix of male and female providers were included, with 78% being female. Younger and older providers were also included, with 57% being in the 35 to 44-year-old age group. The years as a provider that a provider had worked as a family planning provider ranged from less than a year to 20 years, with the average being 9 years as a provider. Consistent with our findings from phase 2, providers liked the content of the tool and e-learning course and found it very relevant to their work. Training in gender competency using these resources was well received and valued by providers. Participants were fully in support of expanding training using these resources nationwide. Here I present one global item from the Implementation Outcomes Survey. The high ratings observed for this one item were also found across other items in the survey, so I use it as an illustrative item. In response to the statement, the content of this module is relevant to the challenges I encounter when providing family planning services, 79% strongly agreed that this was true for the gender-sensitive communication module. 86% strongly agreed this was true for the module on promoting individual agency. 82% strongly agreed it was true for supporting legal rights and status related to family planning. 75% strongly agreed this was true for engaging men and boys as partners and users. 86% strongly agreed this to be true for the module on facilitating couples' positive communication and cooperative decision-making. And 75% strongly agreed this was true for the module on addressing gender-based violence. Focusing more specifically on the tool, I again present one global item from the usability survey. In response to a question about the overall user-friendliness of the tool, the response options ranging from worst imaginable to best imaginable, all ratings were good or higher, with 18% responding good, 64% responding excellent, and 18% responding that the tool had the best imaginable user-friendliness. All of the 6 modules were well received, with favored modules including the ones focused on engaging men and boys and addressing gender-based violence. Overall, providers expressed that the content was new and highly relevant and different from standard family planning trainings that focus more on types of contraceptives. As one provider explained, I was thinking it's just about the family planning methods, the depot, the implant. Initially, I was resisting, but being here has taught me something very different than the perception I came with, for the fact that it points out the client's rights, gender-based violence, and some policies that you need to know as a family planning provider. Given the high acceptability, relevancy, and usability of the tool and e-learning course, our next main questions related to how these resources might be used in delivery of gender competency trainings. Both resources are free and publicly available on the internet. Feedback from the earlier tool workshop was to combine in-person with online training. Furthermore, there has been a rapid expansion of virtual learning materials in Ghana and other settings, but questions remain about whether these delivery formats are feasible and acceptable, so we piloted 3 different modalities for delivering gender competency training. first modality was in person. This structure was like a traditional workshop wherein participants and facilitators meet face-to-face and use the training resources synchronously, meaning at the same time. The second modality we piloted was blended and included a combination of face-to-face meetings as well as synchronous and asynchronous work using the tool and e-learning course. Finally, the third modality was completely virtual, meaning that all meetings occurred online and participants completed the tool and e-learning course asynchronously. The modalities were piloted in different regions of Ghana. The in-person modality was piloted with 14 providers in the city of Tamale, which is in the northern region. The blended modality was piloted with 14 providers in the city of Kumasi, which is in the Ashanti region. And the virtual modality was piloted with 24 providers with representatives from all regions nationwide in Ghana. Our assessment of the modalities used the self-assessment tool completion scores, the e-learning course completion rates, T-notes from implementing the modalities, and large group discussions. There were several common elements to the modalities. The first is that each one included an introduction which explained gender competency and the 6 domains, the format of the tool, including the items and responses, answer key, and discussion guide, as well as how to access the tool online. An overview of the e-learning course was provided, including how to access the course, the ability to move back and forth between modules of the course, and how to complete the knowledge assessment at the end of the course to obtain a course certificate. The image on the screenshot of the, on this slide is of the login page for the course, which requires participants to enter their email and name. By logging in with their email, participants can complete part of the course and return to it again later. A second common element across all the modalities was that they each included a space for peer-to-peer discussion about the content and participant-to-facilitator interaction for questions about content, training expectations, and information technology support given the online nature of the tool and e-learning course. Interactions occurred in person through online meetings and through the social media platform WhatsApp. For both the blended and the virtual modalities, interaction was maintained during the asynchronous learning period via WhatsApp. I'll begin with the results from the in-person workshop. Participants traveled to a central hotel with meeting rooms where the hotel provided internet and meeting facilities. The team also brought a backup modem. Due to the need for additional time to gather feedback, the training took 2 days. However, in real-world practice, completing the tool and e-learning course in this modality is feasible within a 1-day workshop. The agenda for the in-person meeting included 2 main sessions. In a morning session, an introduction and introduction was provided, and the self-assessment tool would be completed, as well as the first half of the e-learning course modules. In the second session, the remaining modules are completed, the tool, and a large group discussion about content, applying the learning to day-to-day practice and sharing with colleagues was then proposed. While in our case, providers were brought to a central location, it would also be possible to send a trainer to facilities to work with providers in their clinic or hospital settings. Providers were given tablets to complete the tool and course in this modality. All 14 providers attending the in-person meeting completed the tool and the e-learning course. We also saw an increase in providers' gender competency score, comparing self-assessment scores before and after e-learning course completion. In our group discussion about the in-person format, advantages noted by providers were that the peer-to-peer interaction about training content enhanced the learning process, and that the in-person format, which was away from their work and home environment, provided a focused space to promote concentration on the topic. As one provider stated, as we usually finish our individual assessment and the e-learning course, and we discuss our different views, I would share and discuss, and that is a learning process. If not, I would not have heard some stories. In terms of concentration, one provider explained, the fact that we are here for this purpose, everyone is concentrating on that one purpose, because that is why we are here. As compared to if I was to be in my house, after all, there is no one to guide me, and I am not under obligation. Another provider explained that during in-person trainings, there is nothing to distract us. The main disadvantage noted by participants is that in-person workshops are costly. Despite bringing participants to a hotel with internet and having the backup modem, we still experienced network challenges, perhaps because so many participants were trying to access the course at the same time in the same location using the same network. We also asked providers at the in-person workshop to give their opinion and suggestions for the other two modalities we would assess, which included the blended and virtual workshops. They hypothesized several advantages of these formats, including that they would provide greater flexibility and when and where to complete the modules, which could be important for participants needing more time to complete the module than others. They also noted that the virtual format would be available to all providers, thereby eliminating possible selection bias in which providers are selected for trainings. Hypothesized disadvantages included that some people would not have internet network, that there may be IT challenges without the on-the-spot support provided during the in-person meeting, that there would be more distractions in terms of learning, and that it could be difficult for providers to find time to complete the training if not in a protected in-person meeting. As one provider explained, for me, I think the advantage would be the fact that I would do it in the comfort of my environment at my own space. Yes, but the disadvantage would be that would I be able to complete it before the time you wanted, depending on the network, okay? Plus you need the concentration. The next modality we piloted was the blended format. Again, participants traveled to a central hotel with internet and meeting rooms for this format. Without the time we needed to gather the feedback, the in-person portion of the blended format could be achieved in one half-day meeting and an hour follow-up meeting. For the first session of the blended format, providers meet in person. The introduction is presented, followed by completion of the self-assessment tool and one of the e-learning course modules. Providers complete a group discussion about the content. They also receive in-person IT support to make sure they can access the tool and log into the e-learning course. Providers were connected with each other and the implementation team via WhatsApp group. They then had 1 week to complete the remaining modules of the e-learning course on their own. During the week, they received follow-up messages and reminders and could ask content and IT logistical questions. At the conclusion of the week, they were brought back together for an in-person meeting during which the self-assessment tool was taken again to give the post-training score. And there was also an opportunity for group discussion about how the content applies to their day-to-day work. All providers completed the e-learning course in the blended format. This was also true among a subset of providers, excuse me, whom we did not provide a tablet and rather asked them to complete the tool and course using their own smartphone. A second subset was sent additional follow-up messages, and we found that regardless of the frequency of messaging, all providers completed the tool and e-learning course and in the blended format. Again, we also saw an increase in providers' gender competency score comparing the self-assessment scores before and after e-learning course completion. As providers completed the modules on their own between the in-person meetings, we asked them to report when they completed the modules. 67% of modules were completed during the provider's off hours, 19% of the modules were completed during work hours, and 14% of the modules were completed both at work and at home. During our group discussion, providers explained that the main factor driving when to complete the training was network strength and availability, which is often stronger during off hours. Some providers mentioned staying at their work location during off hours because the internet was stronger at work than at home. Others explained that they were able to focus more at home than at work and that they completed the work during off hours because they were accustomed to studying at night. Providers explained advantages of the blended modality to be the in-person peer-to-peer support as well as IT support. As one provider explained, peer-to-peer support will help in the case of the online platform or getting technical persons to help with when the need arises. Another provider stated that I think the blended is better because you tend to get more insight through discussions that may come up. Providers describe disadvantages to be time constraints that can prevent completion and can require them to work on the course during nights and weekends. One provider stated time constraints might not allow some people to join online. The third format was the virtual format. There was no in-person meeting with participants, and they all used their own smartphones to complete the tool and e-learning course. The first session of the virtual modality included a 1-hour Zoom meeting during which the team explained gender competency, the tool and e-learning course, and how to access both resources. The group of providers was connected via WhatsApp group and encouraged to send any questions or IT challenges through the group chat. Providers were then asked to complete the tool and course on their own during the next week. They were sent follow-up reminders and information about the second meeting. At the end of the week, they attended a second group meeting via Zoom, during which they provided their opinions about the training resources and virtual format. Only about 2/3 or 65% of providers in the virtual workshop completed the tool and e-learning course. This is a major difference compared to the in-person and blended formats wherein all providers completed the tool and course. Lack of time was the main reason given for not completing the tool and e-learning course. Among the providers who did complete the course, we again saw an increase in gender competency according to their changes in the self-assessment tool score before and after taking the course. More so than in other modalities wherein all providers came from the same location, we saw a greater diversity in provider opinions about the virtual modality. About 2/3 said they would prefer an in-person format, while 1/3 strongly preferred virtual only. Some advantages noted by providers are that virtual trainings using these resources can, in some cases, provide easier access depending on the network. Another advantage they identified was the convenience of working on training intermittently among other responsibilities at work and home, that the virtual format increases the reach to more providers, is a lower cost, and is less stressful for participants because it can eliminate travel, although some providers travel to other communities to get a better internet connection. As one provider explained, they strongly felt that e-learning is the future. She's noted, we have to motivate ourselves that this virtual process way of training is even cost effective. There are times you go to face-to-face workshops, then you frown your face because you have moved a long distance and nothing is being given. But with this e-learning, I can just sit at my faraway distance and I have network, and I'm able to learn what I would have moved so many miles to go and learn. I think this is a good way. So everybody should get motivated to know that e-learning is kind of less stressful and the best for us in the setting in Ghana. Disadvantages of the virtual format included network connectivity issues leading to frustration with course completion, working late nights and weekends, and traveling to other communities for network. It was also noted that for a subset of providers who were born before computers or who were not interested in technology, the in-person learning preference was the main disadvantage to virtual training. One provider described that she decided to do it deep in the night because that is when I get network cleared. I had access to it when the network was cleared around midnight, and then I was able to work on it more. Right now, where I'm currently having my Zoom meeting, I have to go to certain locations and really look for where to do it. Another provider explained, we are not used to this way of training. It's the face-to-face that I'm used to, and that's what I enjoy. Given this diversity in viewpoints, the answer to which modality is best is that it depends on a number of factors. As one provider explained, it all depends. With the virtual, it's good if you have network, but some of us have network challenge. So should we include those who also have that problem? Because that person will not participate fully. My network is very bad. So face-to-face, that one, we are all together learning, and so learning can take place. But the problem with virtual is the network. If the network is fine, there is no problem. At a point, I had network problems, so I have to move to another community, get the network, and sit down and work. We also learned other important provider recommendations that are not specific to modality. These include the recommendation from providers that continuing professional development points be issued for course completion, that there be bonus incentives for completion of the course, monetary, data, or certificates as examples, that the training be included in nursing colleges and other pre-service training, and that refresher trainings be conducted. Providers suggested that managers take the training in addition to direct service providers. A few providers noted that the scoring on the tool made it feel like they were taking a test, and so it is important to de-emphasize the score and explain the larger goal of the learning process facilitated by the self-assessment tool. It was suggested that a short video to introduce the course and how to navigate the platform could be helpful, mimicking what I described in terms of the introduction we included across modalities. Finally, there was a suggestion on how to complement the global nature of the training with locally developed resources, including a document explaining legal rights and responsibilities in the specific country, and referral sites and points of contact for referring clients in order to achieve addressing gender-based violence. We also learned about resource needs through this piloting. It was clear that there is a strong need to provide data bundles to providers, at least 5 gigabytes, for them to be able to complete the tool and course. It is also important to provide incentives, which were monetary during our piloting, but could also include continuing professional development points and certificates. The in-person and blended formats achieved higher course completion rates, but were also twice the cost of the virtual format. Another potential cost is the provision of tablets. While providers noted this as helpful and preferred, providers can also successfully complete the course using their own smartphones, as we observed during the blended and virtual trainings. The common costs across the modalities include data, incentives, and the need for at least 2 implementation team members, one person knowledgeable in the family planning content, and importantly, an IT expert who attends in-person and virtual meetings and also attends to the group chat during the asynchronous learning week. This was key. As one provider explained, I think they should add a resource person because no matter how much you know about the technology or the ICT aspect, I think if there's a resource person when you are stuck, that you call for guidance, that you call them like so-and-so, that would help a lot. Another person noted, this is the first time that I've been given data to attend an e-learning or Zoom meeting. There are other Zoom learning sessions, but I'm not able to join because they just put the link there and said it's supposed to be at this time. But because of my data, as my sister said, most of us are not joining. But you gave us data, so it's motivated us to actually strive to do it. Without data, your zeal is low, but because of the data, you have to try and join. Other IT factors to consider across modalities are internet connectivity being unstable or being slow, which can result in disrupted access to course materials. In fact, during our in-person meetings, slow internet led to extended session times beyond what we had originally planned. It is also important to consider the digital literacy of providers. In our piloting, varying levels of digital literacy affected users' ability to use the platform effectively. Apart from the network itself, power outages and instability can limit network access and in some cases led to the completion of course at work rather than at home. To summarize across the modalities, in-person optimizes peer learning, team building, engagement, protected time for training, but it's also costly, involves transportation, and has a structured learning cadence so that people who might need more time for each module may not have it. In the blended format, we see that it supports peer learning, team building, engagement, and provides some protected time for training for what's conducted together in person, but also gives you the flexible learning cadence over the week so that people can take as much time as needed with each module. However, it is also costly, requires transportation, network, and is network and technology dependent. And finally, the virtual is more accessible in some ways if there's network, has lower cost, no transportation needs, and provides a flexible learning cadence. But it can be less engaging and it has a higher risk of dropout, as we observed here, and is network and technology dependent. So in summary, across all modalities, providers felt the tool and e-learning course were valuable and relevant to their work. Gender competency scores increased for all providers who completed the e-learning course, but providers participating virtually were less likely to complete the course. In all cases, data bundles and incentives should be provided. And in selecting the modality for training, there are a few main factors that we suggest that are considered. These are internet connectivity, digital literacy, and provider preference. We present this last bullet also as a table to help guide your selection of training modality and begin a conversation with your own teams about how you might use these training resources in the future. First, we suggest that you focus on considering internet connectivity, since it was such an important factor across all modalities. Within that, consider providers' preference for online or in-person learning, as well as provider digital literacy. By differentiating how training is delivered using these resources based on these factors, more providers can be reached. We want to thank and acknowledge the many, many people who contributed to this activity. And so we do so on this slide. And now I'd like to turn it over for Q&A.
Thanks for that great presentation, Catherine. We're going to open it up, as you said, for questions and comments. It looks like we have one question in the Q&A box. Thank you for the great presentation. Please elaborate on the feedback mechanism in the case of virtual training. I'm not sure if the person that submitted that question might want to elaborate a little bit for us in the chat or in the Q&A.
So I will say that we obtained feedback from all of the modalities in the same way. Oh, Evelyn, please.
Yeah. So I feel the person wanted to find out how we got the feedback from the participants. And so after they completed the the e-learning at home, we had group discussions, still online. So we had 3 different groups with moderators leading each of the groups, and then we solicited their feedback. I don't know if this helped.
Thanks, Evelyn. Related to that, I was wondering if the choice of modality seemed to affect the quality of the group discussions that you had.
Yes, not necessarily. We were able to get a lot of information. Just that, like we said, the issue of internet connectivity was one of the challenge that we had. And so you get a few people going on and off. But then overall, I think we got very good feedback from people who stayed on and gave their feedback.
Yeah, I'll add that there was actually one quote that I chuckled at because it's such a common experience, I think, anywhere that you are and attending to Zoom meetings that, a good portion of the Zoom meeting, it was about an hour long, was getting people to mute themselves as they join, or new people muting, or people maybe a feeling that they can take the call in a space that may not be like a work environment, maybe like in a market. And so quieting the background noise was a common thing that happened. And then there is a little bit of less of a natural kind of interaction where you might be looking to see who's going to speak next, or maybe people start speaking over each other. Always there was 1 or 2 people that dropped out, but then had to rejoin. So a lot of things that I think many of us have lived experience with, excuse me, with Zoom did affect that to some degree, I think, in doing it all virtually. Now, I think that colored the interaction. The completion of the e-learning course, which is self-completed, everyone does that on their own. One of the very nice things about it is that you can come in and out of it, and it's not disrupted by like that kind of live, the synchronous kind of sessions. Yeah.
Thanks, Catherine. Thanks, Evelyn. Rolf Clem in the chat is saying great presentation, very clear on the different processes. He's curious about the size and meaning of the pre-post differences in scores, noting that the range was 3 to 5 points. Is that a meaningful change and what you expected? It seems quite small.
I can take that one, and then maybe Catherine and Evelyn can add. If you look at the self-assessment, a lot of it is quite basic. And so I don't think that these changes in scores are all that surprising. And I attended the pilot in the phase 2 meeting, and we actually asked the participants about this. Is it too easy? Is it, because everybody's scoring very well. And they said, no, we appreciate, for some of us, it's review, the average amount of time in practice was 9 years. So a lot of it was review, but it was review that they appreciated. And then those gains that they did have were quite significant, maybe not in terms of scores, but in terms of learning. So in Ghana, we found that like the legal frameworks were not something that people had necessarily thought about. So the fact that they learned that, it only changed their score a little, but it was a big deal to them. And same with some of the gender-based violence content. So not a big impact on the score, but it was good learning for them. Evelyn, do you want to add anything to that?
No, I think it's fine.
Thanks, everyone. Next question is, can the tools be used by program managers implementing family planning projects?
Yeah, yes, and we hope exactly that the tool and the e-learning course that is exactly why they were developed, that they are used by managers. We envision it could be used by managers, it could be used by individual providers, it could be used with managers to do with another colleague or a group of colleagues. It could be used in supportive supervision. So we hope that there are many ways in which managers might choose to use these publicly free available resources with their family planning providers.
Next question. Do you think you will give the assessment again after maybe 3, 6, or 12 months to check on retainment of the training among the providers that participate?
We think that's a great idea. It's definitely something that we've talked about. We are also coming to the end of this activity, so there isn't really timeline to allow for that, but that would be something that would be great to do in the future.
And which of the training processes will you recommend in a low-income setting?
So I actually am going to go back to this slide and I will say all the tools and this work is being conducted in a setting that is similar to that, a low income setting. And I think that the hard part of this is that there's not one size fits all, but I think a need to know about the providers and their availability. I mean, the truth of our experience, and that I think people can assume virtually, is that it is lower cost, right? So it would cost less for a national program or for an organization to do everything virtually. But there were some drawbacks to that. Like there are going to be, on the one hand, we assume that virtual means that it's accessible to all. And in some ways, you saw the participants saying that themselves too. Like it doesn't, you don't have the selection bias of who gets chosen to go to a training or who has the time to be able to travel. But other people were excluded from the actual learning process in the virtual training if they didn't have digital literacy that would allow them to feel comfortable in that kind of learning environment, or if they in theory might have had access because it's on the internet, but where they were didn't actually provide them that kind of access. So as you saw in a number of the quotes and the feedback we got, sometimes people were actually traveling to get to a place where there was network. So there are still some things that limit access, even though it is something that in theory could be done everywhere if there was access to internet. And so I think in a low income setting, I would use some combination based on your internet connectivity, how strong the network is, and also thinking about the providers you're trying to reach in that training. So it may not be the same approach in every region that you use or with every group of providers that you use the training with. And we hope that kind of working through this and thinking about, well, who are the providers I want to reach? That you might go down what we have here in the rows in terms of like, what's the level of digital literacy or preferences? And then do they have internet connectivity to kind of choose between them? Let me stop there and see if the other panelists might want to also jump in here.
Yeah, I would just reiterate something Catherine mentioned early in the presentation. We didn't test this model, but you could send a trainer to a facility as well, which would be probably less expensive than bringing all of the trainees to a site. So that's something that could reduce cost and still allow people to have that face-to-face interaction.
Thanks, Shannon and Catherine. Another question from Dr. Clem. The real test for training effectiveness is to measure changes in how services are provided and perceptions of women on the quality and responsivity of those services to their needs. Do you have any plans to follow up on whether the training has influenced any of these high-level outcomes?
So currently, not with the current activity, but I think we showed the multiple phases that there are, and we agree that the ultimate test of training is to see how people are using this in their day-to-day practice. And so following up with that and seeing, talking back with providers would be a great idea. Perhaps something that Ghana Health Services might be able to do as they continue to work with the training and the providers that participated in this. Our current activity doesn't have plans. Again, this is the kind of final phase for what the current project is doing. Although I will note that, this project, one of the really nice things is that USAID has supported this across projects and across countries. So all of the materials have feedback from Ethiopia, the Philippines, Uganda, Ghana, and there's a real sense of trying to understand how this can move to like real world implementation. And I think that's a great idea for a next step.
Thanks, Catherine. You all had mentioned that providers found the training highly relevant to their work. Were there any modules that stood out to them as especially relevant?
Yeah, I think basically from most of the interaction we had, most of them participants were so much excited about the gender-based violence, especially with the fact that they feel this is not relevant. Initially, they thought it has nothing to do with family planning. So they were excited about knowing this, even though some of them mentioned the fact that they actually need to know where to refer some of these cases. But then it was one of the things that people were really excited about. And then the fact that men and boys were also included, that engaging men and boys mostly in Ghana, attention is on the women when it comes to family planning. But the fact that now they are involving the men is a good thing and something that they will encourage other providers to take note of and implement.
Catherine, Jana, anything to add?
And then I think the module on the legal environment as well. People aren't always, I know I'm not up to date on every law in the United States, and I think it was the same for these providers, that kind of hearing an update on the legal framework was helpful for them. But I think this will vary. I mean, that was Ghana, and I think this will vary depending on the setting where it's implemented. So if you did this in another country, they might resonate with other modules more. It'll depend.
Speaking of country context, we all know gender norms are very context specific. Are there ways to tailor the training to different places?
I think one of our recommendations was for countries or national health programs to develop kind of a product that comes alongside of this to get more specific about the situation in that country. I think long term, this tool and this training were developed for a very kind of gender binary setting, and in places where that doesn't necessarily apply, you might need a different tool or need to adapt this one.
Well, I don't see any other questions in the chat or the Q&A. So with that, I think we can say thank you to our panelists and to our participants for your time and your participation. And please check out Data for Impact's website for more resources and materials related to this and our other work. Thank you all.